Welcome to the Byja radio show. I'm your host, Dr. Byron Jasper, and we are recording live from J. Kinba Executive Suites in Baton Rouge, Louisiana, with special production by Becnel Media. And we are back. We are back once again, back for season 2.
Season 2, man.
Season 2, man. That's pretty impressive because we have to get people what they want. And people want Byja Radio, man. I only say that because I think I sent you a screenshot earlier today where we actually had one of the doctors I ran into at a conference was saying, when's the next episode coming? So at that point, I
ready to get it.
I was happy to tell him that, we were going to be putting out one pretty soon, but we had to take a little bit of a break, All great things happen in seasons for the most part.
True.
We're talking about sports, we're talking about weather, talking about, just different seasons of life. I think altogether what we're doing is putting out great things here. Mm-hmm. And if we're doing that, we got to sometimes refresh and replenish.
Yeah,
so
absolutely.
Welcome back, everybody. Again, season 2 Byja Radio. We are on episode 12. Episode 12. So I don't know, in your book, it's 12 a lucky number? Anything specific stand out for you for episode 12?
Well, back in the day when my dad would take us to Dim's Bakery, my parents used to take us to Dim's Bakery and get those donuts.
Yeah.
That 12 was a good number then, boy.
There's always a donut, right? It's always a donut number.
Get a dozen.
There you go. I'm not mad at it. I'm thinking you was gonna go flowers or roses, but you went donuts. Clearly, that's not a health show at all.
I'm not. Yeah, right. I'm not a flower guy.
The health guy is not happening either. We're straight into. You could have went eggs.
Well, but hey, man, I don't really eat eggs like that. But I've been gluten free for about a decade, so I got fond memory of donuts.
Going back to those pleasant.
And then look, bro, like that's what you here for, man. Like I want to be able to eat complete crap, and you keep my A1C in check, bro. Like that's just what this is.
That's why I'm raining on your donut dream right now.
Man,
that's what I'm doing.
That's what it is.
Well, you're welcome. Let's start there.
Yeah.
So today we are talking about a topic that I believe a lot of people deal with. Mm-hmm. Some more than others, some that are dealing with it from a family standpoint, some internally. Mm-hmm. And I believe the cue up for this one was a pretty easy question that came from a fellow doctor. And that doctor was just like, look, can you talk about this? We listen in and we want to know if this is something you can explain, being a important topic for us in healthcare, and how can increasing accessibility to this will be most important. So what we'll do is pause and let George do his thing, and we'll go to the question and we'll come back in and give our thoughts. George, if you will.
Hi, Dr. Jasper and Patient Zero. I'm a fellow doctor and been telling a lot of patients and students about the importance of integrating mental health care into primary care. Can you explain why this integration is so crucial, and how does it help address common mental health issues such as depression and anxiety more effectively?
So I need to take this time to apologize to the people.
What was the apology for?
Because I have this I had this question queued up, and I missed a golden opportunity when you said you got to give the people what they want. I should have had the OJs playing
a little bit of background.
Because that's the jam, bro.
Yeah.
And so I'm sorry.
Yeah.
Anyway,
you're slacking. But
great question, though.
Nevertheless, yeah, great question. So we're talking about primary care, and we're talking about mental health, and how putting them together oftentimes is a good strategy, but also how it can, in essence, help people have better care. I think overall what we tend to see is people will have an idea of going to primary care as one thing and then going into mental health or behavioral health as something different. So we're trying to basically say, okay, well, how can we merge these two together? And if we're putting them together potentially in a integrated setting, or if not a direct primary care setting, is there a potential for us to have better outcomes? So what we'll do is kind of kick it off by giving a few statistics. And since George loves statistics, he gets extremely excited when we go over statistics.
Numbers make sense.
Yeah, if it don't make dollars,
it don't make sense.
So we got to know our numbers, right? So I'm gonna read a few of them that I came across when looking into this topic and looking things up. So nearly 1 in 5 U.S. adults live with a mental illness. As of 2020, it was about 52.9 million people in the U.S. that had potentially a diagnosis of mental illness. And this is coming from the National Institute of Mental Health. It's not a number that I just made up. I know a lot of people think that, but no, this is actually something that is documented. And common conditions for mental health are anxiety disorder, depression, bipolar, sometimes even schizophrenia. And based on the numbers that I looked up, they were estimating that there's about 19.1% of adults out there with that anxiety, 7.8% with depression, and then the numbers decrease from there.
So I think that's low.
I'm sure.
And the reason why I think that's low is because I think, to have an official stat, it's got to be diagnosed and documented.
Yeah.
And I feel like when you're talking about mental health, this is the one thing that people ignore the most because they feel like you can just keep on trucking and just ignore or mentally overcome the issue.
Yeah.
You know what I mean?
I agree.
So I would assume if I had to guess, I would assume that this number is like 3 in 5.
Yeah.
Versus 1 in 5.
Yeah, because I think the stat that we are looking at is probably, as you said, official diagnoses, as opposed to people who are diagnosed where they know something's wrong, but they're not necessarily going into a clinic. They may have been diagnosed, but they're not sticking with care, not having that continuity, or people who just in flat out denial. Right?
Yeah, absolutely.
So, I think that number is definitely underreported, but again, it gives us a starting point that it's not this extremely arbitrary thing that you're seeing people who are in 52.9 million. That's still quite a bit of people, right?
Yeah.
Some people may think it's less, but
I think it's more.
A lot of people think it's more.
Then the first thing you listed was anxiety disorders.
Yeah.
20%. Come on, bro.
Yeah.
Like, think about everybody out there with like road rage.
Yeah.
You know what I mean? Like that has to be a form of anxiety, or everybody that's freaking out about their jobs, or everybody that's just dealing with life. To say that it's only 20% of adults got anxiety disorders or anxiety issues, I don't buy it.
Yeah, and I think that's the thing a lot of people are surprised about is that mental health is not necessarily the worst of the worst. When I think people think of anxiety or depression, when we have the conversation in our clinic, they're thinking we're saying that you have to be in the worst space ever mentally.
Yeah.
You have to be, so down and depressed that you don't want to leave the house ever. So therefore, if you don't feel like that, you're not depressed. Or for anxiety, you have to feel so anxious, you're having all these panic attacks. And if you're not having panic attacks, you're not anxious, you don't have anxiety. And that's not the case.
Not at all. So like, in my opinion, or not in my opinion, just from what I gathered growing up, you think about mental issues were extreme things.
Yeah.
Like mental issues, I don't even think depression was considered a mental issue. I think depression was more of a feeling that people, not that it was a feeling, but people looked at it like a feeling.
Yeah.
Like you extremely sad, they attach depression to it, right? Mental issues were schizophrenia, bipolar, not Parkinson's, what's the other one? Alzheimer's. Like that was like mental issues, but anything short of that was just more or less of your mood. You know what I mean?
Yeah.
So the fact that we're talking about anxiety, we're talking about depression, I think a lot of people still look at those things and not take that seriously.
Yeah, I agree. And that's part of the reason why we're trying to give some of those statistics. So going a little bit further, these are general numbers in the general population. So we'll move into how does this come into play when it comes to primary care. So another stat that we looked up was from the Department of Health and Human Services, and they reported that studies show approximately 30 to 50% of patients who are in primary care settings suffer from some type of mental health condition, with depression and anxiety being at the top of that list. So 30 to 50% of people are potentially diagnosed with some type of mental health condition. And most of the time that could be in a primary care setting. Now, again, depending on who you are and what seat you sit in, some people may say that's a accurate assessment. Some people may say it's low. Some people may say it's high. I'd say that 50% of people having some type of diagnosis is possible. The question is, how severe is it that it warrants treatment or it doesn't warrant treatment? And that's the question I think a lot of people struggle with. You can have anxiety or depression and not necessarily need the most treatment where you're on medication or counseling or therapy. It can be something that comes and goes. It could be seasonal, as we talked about earlier. But a lot of people don't want to engage in that conversation. They kind of white knuckle it and just say, I'm just going to push through. And if they are in that setting and they're not necessarily getting the care they need, sometimes it just gets worse and worse and worse, and Absolutely. It spirals out of control.
So, before you go further, I want you to define what would you say is mental health treatment for the listeners? Is treatment only counseling, or is it treatment only medication, or is treatment both, or can it be other things? Like I want your opinion, or your medical expertise on what treatment of mental health issues is.
Yeah, and I think that question is fair. And the first thing I always try to set the tone about in my exam room is that it depends on the person, it depends on the diagnosis. As I just said, there are different levels of diagnoses, and there's ways that we screen and or diagnose depression or anxiety. Depending on that screening, depending on that diagnosis, some people may only need one form of treatment compared to another. Some people may need a more comprehensive, complex treatment, but treatments span different approaches. The main ones you'll see in most mental health settings is counseling. We use the term CBT, or cognitive behavioral therapy. Cognitive behavioral therapy, or CBT, is basically therapy. It's counseling. It's talk therapy. It's when you're talking to someone about the problems that you're having.
Correct.
Those problems are potentially things that are causing your mental health not to be where it should be. So we're trying to do some type of therapy to get a treatment or solution to what's causing you to feel that way. So that's one form of treatment. Another one is medication. A lot of people don't like the idea of taking medications for mental health because they think it causes a bunch of side effects or it makes them feel differently. But the trade-off for that is not all medicines are the same as what they used to be. I was talking to one of our patients not too long ago, and the short version of this story is that I was explaining to her that medicine always is advancing. Rarely do medicines stay the same unless they're very old and unless they just really work well. When medicines don't work well, eventually they kind of go away. They kind of fall off and we don't use them as much. If it's a solid medicine that has withstood the test of time, then we keep using it and taking it outside of mental health. When you think of things like antibiotics, there are some antibiotics that are just around, right? Most people know what penicillin is, and penicillin is an old antibiotic.
Right.
But there's new antibiotics that people probably have never heard of, unless you're in the hospital or unless you work in a hospital setting. Things like vancomycin, which is extremely strong antibiotic that's pretty much IV only for the most part. And the IV antibiotic, we don't use it a lot because it's a lot newer and stronger, and we use it for very specific settings. The reason why I bring those two up is that we still use penicillin all the time. It's old, it works well, it's not in a bad form, so we use it. Sometimes we don't need those very old medicines, we use the newer ones. So in mental health, we're very similar, that there are a lot of old mental health meds that do have bad side effects and a bad name and a bad rap. We don't use those as much. The ones that do work that aren't old, we still use those. So the newer meds are coming out are usually a lot better, less side effects, less interactions with other drugs, and those are going to be helpful in addition to or separate from counseling. So sometimes we need counseling, sometimes we don't. Sometimes we need medicine, sometimes we don't, and sometimes we need both. And those are kind of the things I would see. Now, there's different forms of medication. Most people know that, but there's also different forms of counseling where you might have group counseling, individual counseling, family counseling, couples counseling, trauma therapy, right? There's all these different types and different specialists within those different spheres that will help you do what kind of counseling works best for you. If you're trying to have a child and you're having trouble with conceiving, then there may be reproductive counseling.
Sure.
And people don't know that's a thing. So when I have people sit in front of me and I'm explaining to them that, look, you may want to consider talking to someone, it automatically turns into a extremely interesting dance, is the term I use. Because depending on what one person says, it's almost like one person is making a certain step in a certain direction. You have to either go with them or you have to try to match their step and give them the best advice possible. And it's very, very difficult at times, but it also is very unique when you can get it and get it right. So all of that being said, I think what people fail to realize is that in that 30 to 50% that we just touched on from a primary care standpoint, that doesn't mean everybody needs medication. It doesn't mean that everybody needs counseling. It doesn't mean that everybody needs either of them. It could be, look, you're having some depression because something just happened, and that's going to basically take care of itself.
Right.
You don't need anything. We're just going to keep an eye on you and check on you. You may also have a case of depression that's so severe you need to be in treatment ASAP so it doesn't spiral out of control. And we have to have those honest conversations because that doesn't often happen in that traditional primary care setting. And one of the challenges that we know of, and we talked about all the time in the direct primary care field, is the time to do all of this. If a person comes in and has extreme anxiety, extreme depression, and you're trying to get them to realize that this is a diagnosis and we need to treat them, and a person isn't really understanding what it is, because it's hard to really know that my mental health is not what it should be. Especially if you're used to feeling this way for so long, you tend to start thinking that's normal. When you don't have enough time, it's hard to do all of that and have the empathy to have that conversation with someone in a way that hopefully gets them to buy into, I need to get this looked at and treated in some way, whether it's counseling, talking about the thing that makes me feel uncomfortable, or taking medicine.
Sure.
So having to do that, that is something that we see in that traditional system, that it could be much better, but it's not as easy to do as, oh, well, you know, people have mental health, we got to give them medicine, we got to give them counseling, everybody's going to be happy. You got to have the right approach, the right time, the right bedside manner, and all these things. And in the traditional setting, it's hard to do in a primary care field where I see you have a huge look of depression or anxiety, and now I have to, again, in 10 minutes, diagnose you, get you to buy into therapy, get you to buy into taking medicine, and then come back and see me and hope everything's okay.
Yep.
So I think it's easier said than done to say in primary care, we're just going to magically fix this, right? Even if you're in a mental health care space, a psychiatrist, a psychologist, a therapist, you often know that it takes a long time to get that relationship built up where a person trusts you to tell you what's going on and to take medicine and to listen to your recommendations because you're affecting their mental health. And all that put together doesn't come lightly. So outside of that barrier, any other barriers do you think that we are running into in that traditional setting, considering all that we just talked about? We're talking about, again, having to diagnose somebody, tell them that they have this unfortunate disease process, right? Then explaining to them how the treatment works. And most people have never heard of these treatments, right? A lot of times you kind of know that if you're sick and you have an infection, you're going to get an antibiotic or you're going to get something to treat that infection. A lot of people aren't used to being treated for mental health because it's so new for a lot of people. So having to get them to buy into that, that's another thing, right? Besides the diagnosis itself and having time to do that effectively, it's buying in the treatment and then, you know, sticking with it. What other factors are barriers for you that you possibly would see or have seen when it comes down to diagnosing and treating mental health from a primary care setting, from your experience, if you had to think?
So it's a couple of things. Number one, I agree with you in that time issue, because these conversations, or you know, they need to be longer and drawn out because there's a stigma, right?
Yes.
Obviously, there's a stigma where I think people, the general public, and especially in the Black community, we're more receptive to being treated or acknowledging something is not right with us physically, more so than something is wrong with us mentally, right?
Yeah.
So that stigma is a thing, number one.
Yeah.
Right. Number two, the way the medical system is set up, where it's like, if I come to a primary care physician and I feel like I have any other issue, whether that's like an allergy issue, or if it's a orthopedic issue, or if it's anything else, I feel like I got to go to some type of specialist anyway. So then that's all physical. So I think it's also a barrier to have that conversation with your primary care physician, because I feel like it's like, what do you know about mental health anyway?
Yeah.
Like, I think there's a question or like a doubt in your primary care physician's knowledge or ability to diagnose and maybe treat a mental health issue. You know what I mean?
Yeah.
So I think those things are probably the biggest barriers in my mind, especially the stigma, man, because people don't want to admit or want to hear that something might not be 100% with them mentally.
Yeah.
Like it's an attitude where something's wrong with you, but it's not looked at like for example, if you have a cold, you can admit something's wrong with you, but it's temporary. I don't think people look at a mental health issue as something that's temporary that could be helped out. I think they feel like they're broken, and I think the receptives to accepting that there might be something temporarily wrong with you is the biggest barrier that out there to even dealing with this.
Mm-hmm. I think it's a twofold approach, though. I think you hit on one that I'm going to spend a quick moment on. The stigma part. I think the stigma is not only internal stigma, but it's external. Internal, as you said, if I admit that I have depression, then something's wrong with me, and I don't want to think something's wrong with me.
Correct.
I twist my ankle. Okay, well,
I can see that something's wrong.
I know, and that happens, right? But me getting depressed, I mean, that doesn't make sense, because I'm resilient, right? I don't get depressed, right? That's not something we do, especially as black males. Like, we can't be depressed. That's just not something you do, right?
Or also, not to cut you off, but you think about it, especially in the black community, we're overly spiritual. Yeah. So it's like, and I'm not telling anybody not to be religious. That's not what I'm saying. Yeah. But what I am saying is, you feel like you would go to a doctor with a cold, but it's almost like if you have like a mental issue, it's almost sacrilegious to admit that you have a mental issue. It's almost like doubting God. Like, nah, bro, God put this medical doctor here just like he put this counselor here to help you mentally. You know what I'm saying?
Yeah. And that diagnosis too, right?
Right.
That happens as well. So, and you just hit the nail on the head, that the stigma from an outside factor, right? The religious group may not necessarily want you to believe that you have this depression or anxiety. Not all of them. Some of them are a lot more welcoming and a lot more forward thinking about certain diagnoses than others. But it definitely happens that you'll have people not feel like I can talk about my diagnosis because I'm going to get judged, or someone's going to think less of me, or I'm not going to be able to do certain things. And one of the biggest places that stigma exists is in employment.
Yes.
In employment, you tend to see that if a person has a diagnosis of depression or anxiety or OCD or all of these other things that you've heard of, they're not only a liability, they are not stable enough to do the job anymore. And because they're not stable enough, I don't think they need to be here. And then all of a sudden promotions don't happen. You don't have the ability to move up in the actual corporation if you're working in that setting. You don't get raises. Like, all of a sudden your work is questioned. Your ability to perform is it's a house of cards that is quick to crumble. Right. And it's all because of stigma. Because most people who are making those decisions about your ability to do or not do, and your ability to proceed and not proceed, they have no idea what they're talking about.
Right. And it's weird because, mental health issues is like physical health issues is temporary. Yeah. A lot of them are. If you, for example, like if you had COVID, you can't work for 2 weeks. Yeah. Just is what it is. Yeah. But if somebody said, oh, somebody has anxiety, you're thinking, oh, that crazy. Yeah. They now don't matter what they've done in their whole career, now they have anxiety. Ooh, this person, you can deal with that and work through that, just like a physical ailment.
Absolutely. You can have a season of depression or a mild case of depression or a depressive episode. Doesn't mean you have it forever.
Correct.
And a lot of people don't know that, because to them, they have the most impressive medical background ever. There's a med school, I don't know if you heard of it. It is the Google Med School. Okay, Google University.
Google, and the other one is WebMD.
Yeah.
That university, yeah.
Google College of Medicine is where I see a lot of degrees come from, and everyone likes to come and tell us what they know and what they don't know, which is fine. I have no problem having a dialogue, but at a certain point, it's a waste of time to argue about something where a person is really trying to tell you what they do or don't know, and you can see that they have no idea what they're talking about. I think there's a statement that says, never argue with a fool, because soon there'll be two of you, or two of them.
True.
So you're arguing with an employer that a person needs time off from work to deal with their mental health, and they're telling you that they need to be able to report to work in a week, and you have no idea what they're dealing with. You have no idea why. You have no idea what the diagnosis or treatment is. And then when they start to learn those things, then they feel like they can really and truthfully force upon a person what they're supposed to do, when they're supposed to come back, how long are they supposed to be off, how many days are they supposed to be in counseling. And it's that, College of Medicine that they went to on that Tuesday night that all of a sudden gives them the right and the authority, and that stigma just gets worse.
I just find it funny that a corporation that deals with telecommunications can tell you, a medical doctor, about medicine and health. I'm always amazed at things like that.
And it some of the questions we get about what the person should or shouldn't be doing, and just like, it has nothing to do with anything. It's just them, grasping at straws. So the stigma being one of them, if not the main one, I think makes mental health so tough to treat. You also mentioned about lack of training, which is a whole nother conversation. I bring that up for one specific purpose. If you're in the room with someone who doesn't know what they're doing, it's going to be often a regular occurrence that they're going to misdiagnose or miss something altogether. So you are having extreme chest pain and headaches and feeling dizzy, and this person is literally throwing the kitchen sink at you and giving you medicine after medicine, when it could be a panic attack that doesn't need all that. It needs more, let's figure out why you're having these panic attacks rather than medicate you. Same thing for insomnia. We had a whole episode on sleep, and people come in and the first thing they say is, I can't sleep, I need medicine, and no one's really talking about why are you having trouble sleeping. Instead of saying, why don't we calm down your anxiety with medicine, how about we really delve into why are you having these anxious feelings? Why are you having these panic attacks?
So what you did was you opened a whole new can of issues with that comment, because what happens is, and I don't want to always make every episode just a sell for the direct primary care model.
That's okay.
But
we can sell it. I know a guy who knows a guy.
But now, what you just said was, think about this, about not knowing what people's training are. You have a primary care physician that you may or may not have a relationship with because you only see them for 15 minutes, and then they're booked up. So something happens very fast, and then you go to urgent care. You go to urgent care, that's somebody who you have no idea of, you've never seen before in your life. You probably never see them again.
Training may be questionable.
Right. How do you know this person's credentials and trust that they're telling you the right thing from the beginning?
Yeah.
And I know, like, it depends on how bad you feel. You might be a little desperate because you feel like crap.
Yeah.
Understandable.
Yeah.
So you have no choice but to trust this person. But at the end of the day, how can you?
Yeah, absolutely. I agree. And the lack of training, the lack of time to build that relationship in traditional model is all pertinent, but it definitely lends to something you just mentioned, the lack of coordination of care between the primary care side and potentially the mental health care side. Sometimes they overlap because some primary care clinics may be well equipped and well versed in doing a lot of behavioral health treatment to where they may not need to refer. But I often say I'm very comfortable in my clinical training to know what I don't know. And when I don't know something, there's a line that gets drawn mentally, physically, whatever you want to call it. And I say, I'm not going to cross this line because this is when I start to get into I'm doing too much. And when you have someone who's doing everything, they oftentimes miss things compared to having enough to say, this is where I'm good, this is where I know, and then from here, I'm going to hand this off. So if you don't have coordination of care, that means the primary care doctor is now having to literally do everything him or herself.
Sure.
And now they're overloaded. And now they're, again, trying to treat stuff that they are missing or misdiagnosing. Then if they do know they need to refer, but they don't have a good coordinated effort, who are they going to refer to? And if there's no mental health professional in the area that accepts or takes the insurance, then you know you want to refer, but there's nobody to take it. So now the person's just getting untreated or mismanaged. So
that's a fact.
And again, that's outside of stigma. Let's imagine that there is no stigma. Everybody's happy, but I still can't refer you to the person you need to get to because there's nobody around or they don't take your insurance.
Correct.
Or, hey, I can do it all myself, but I'm also missing on the idea that I need help. And then, of course, as we just mentioned, if you're not trained and you don't know what to look for, you're going to overlook stuff. So there's a list of problems in the mental health space. And in Louisiana, being specific, there aren't a ton of primary care people who are well-trained that can diagnose and treat everything, let alone mental health. And then from there, you're going into, now I have to coordinate this care with someone. And who am I going to refer to? But there are not a ton of psychiatrists that you can refer to that all accept every insurance. So you're starting to get into a lot of spaces where you're dealing with a problem that's about to have an avalanche of just bad outcomes.
So how can you be a primary care physician and not be able to diagnose basic mental health issues?
It's all about training. It's no different than anything else. If I've never trained on certain things, I may think I know what I'm doing. That doesn't mean I'm doing it correctly. And that happens all the time. I've had people I have had to train because I was a faculty member at one point, meaning I was a person training new doctors how to be doctors. And if you, the teacher, don't know how to do it, how can you teach somebody how to do it? And that happened to me, not outside of mental health. Fortunate enough, my residency, we had a good behavioral health program in the residency that taught us how to recognize depression symptoms and anxiety symptoms and insomnia symptoms and how to recognize it enough to know when treatment was necessary. That was one thing, but I'll give you an extreme example. And at some point we'll talk about this on one episode. HIV care. You know by now, and most people know by now, that I treat a lot of HIV patients in my practice because it's one of my things that I specialized in. Do you know when I started learning about HIV care?
Residency?
It was in fellowship. I learned absolutely nothing in residency about HIV care other than we need to refer them somewhere else. Do you know where we rank in the city of Baton Rouge? Where do we rank?
Nationally?
Nationally.
I would say it's the top 5. It's got to be like number 2, number 3.
Right. So we're usually number 3 or 4. The city of Baton Rouge is 3 or 4, and then New Orleans flip-flops to 3 or 4, or 4 or 5. So we have 2 cities about 60 miles apart. We're in the top 5. And you know how much training I had on that?
That's terrible.
Nothing.
That's a lot of HIV on I-10, bro.
A lot of it. Extremely. The amount is insane. And the fact that I learned nothing about it had nothing to do with there's not a lot of prevalence. There's not a lot of people with it. It had to do with the people I'm learning from. They didn't do it. So how can they teach me if they don't know?
So what you're saying is every doctor who goes through medical school, goes through residency, they all don't know the same things. And if you have a doctor that's well versed on different things, you're a lucky one, is what you're saying.
I think that's a way to look at it. I will say there is a set standard of things you have to learn to pass and graduate certain levels. Med school, residency, and becoming board certified, there's a certain standard. Certain things fall outside of that standard, right? So there may be
mental health issues fall outside that standard?
I think mental health falls in the standard, but it's how good are you at it? Because and there's two other things I want to point out. So I'm glad we're talking about this. I actually had a conversation earlier today with a student of mine who unfortunately had some issues with an exam called Step 1. And if you know my story, me and Step 1 ain't never been friends, like Casanova and Romeo. So based off of that, I'm literally having a conversation saying what happens with a lot of people is that there's 2 types of learning that happens oftentimes in the medical field. There's what we call book learning, and there's actual patient care. You can be the best test taker and know everything in the book and be the worst doctor ever because you don't know how to care for patients. You can be the best doctor and know how to care for patients, but don't know as much on the paper clinical side. So you're trying to put it all together, and that's why you don't see as many people who start off going into the medical field finish, because they can't put it together. You can take all the tests, pass all the exams, and still not know how to take care of patients, have horrible bedside manner, don't know how to empathize, don't know how to actually do things in a way where it's efficient enough to turn patients over and move from room to room. Like, all that takes skill. You also can be really good at moving from room to room, talking to people, shaking hands, all that stuff, but don't know how to diagnose and treat. So yes, there is a standard that you follow, but it doesn't mean you're great. And some people really get caught up in statistics of, well, you went to this program, so you must be really good. Not true. And I've seen people come out of programs that are really quote unquote prestigious and still not be all that good, versus the person who literally came from the no-name program that you never heard of and they're rock stars. So I bring that up to say, in mental health, as you just asked over and over, can you be in mental health and just not really know it really well? You probably know some of it, but can you really know that, hey, this person's allergic to these 2 medicines and had really bad outcome with this medicine, so now I got to find a 4th one. Well, I only learned 1 because in my residency, we only use this 1. So you don't know 2, 3, 4, and 5. So that's a level, right? So there's levels to get to. How do you go from very mild depression with very mild symptoms that needs this type of treatment versus very complex depression with trauma and anxiety that now warrants not only 1 prescription medicine, but also a counselor and then a group therapy. Like, that's a whole picture you got to put together. And if you don't have enough time, you don't have enough training, this person is very much worried about what's going to happen at their job because of stigma. And, oh, by the way, I need to refer to 2 counselors, but don't nobody take their insurance. It's literally you're playing a card game and you got 1 card to play and everybody else got a full deck. It's a really bad system, right? And in our system, in the direct primary care system, we're having to find ways to make things happen creatively, where we're coming out of that system with the training being somewhat good, depending on where you are, depending on the resources. Because again, and I'll give you one more example. You're in a major metropolitan city. Do you think you're going to have more resources than if you were in a rural city?
Rural close. Yeah, absolutely.
So if your training came from a rural setting where you didn't have a lot of resources, you may not be as equipped to refer somebody to these 4 people. And now that's a gift and a curse. I got to learn how to do a lot more with a lot less in a rural setting.
So I think what you said just now was a lot, and I can't understate what you just said, because as a patient, you know what I mean? I don't, and I think I speak for everybody who's not a doctor. I assume that you went to medical school and that you know everything about medicine. So like, I'm instantly trusting you because I believe that you know everything that you need to know to fix me. So the fact that you just said about that, you just commented on the training and the different levels and the depth of things like that, and how everybody don't get the same thing, I think that's huge. And I think you can't understate that, because people don't know that. You know what I mean? And I guess it's no different from anything else, in terms of, you have people that's good at, like, for example, you have like the Lakers, right? Back in the day, you had Kobe Bryant as a guard, and you had Smush Parker as another guard. They're not the same. They're both professional basketball players, but Kobe was a lot better, right? So, I guess you don't really, as a patient, you don't really think about that in terms of doctors,
right?
And that's something that people who are listening need to really consider. And what that said to me is, well, I'm comfortable because you're my doctor and I'm good. But I think people out there really need to understand who their doctor is, what their experiences are like, what their history is, and see if that's something that matches up with you, because you can't just afford to put your health in the hands of somebody who might not be trained in what you have, because think about it, the way I look at it is like that primary care physician is your point guard. Like, you may not be able to take all the shots, but you need to put the ball in the hands of the person who needs to make the shot. And if you're not playing that point guard, playing that quarterback well, then my health will suffer.
Yeah.
You know what I mean? And I think that's the biggest, and I know we got more episode and I know we're going to talk about takeaways and all this stuff, but I just really want people to understand that, because I think that's really, really big on your comments of what you just said, that you need to understand who your PCP is and make sure they have experience that lines up with what you need. Because, like, for example, like what you just said about HIV, if I would assume that, if somebody had HIV and they had a primary care physician who didn't know anything about HIV, you can't just blindly send them somewhere.
Yeah.
You know what I mean? You gotta have at least some type of working knowledge to know where to send them. And that's huge, because we just assume as patients that everybody has a working knowledge or has a certain knowledge about everything medical. And what you just said that's not the truth.
Yeah.
So
not even close.
I think that's huge, and we cannot understate that for people who listen.
Yeah, and it takes into the perspective of what you just said. In mental health, it's the exact same set of circumstances. When you say, in HIV, people can say, okay, well, I kind of get that, everybody doesn't know HIV, and if everybody doesn't know it, you're going to have somebody who really understands. Mental health is the same.
Yeah.
You have to have somebody who really either understands how to diagnose and how to treat. And if you're in our practice and you're a patient of ours, and we've had this discussion before, it's not out the gate of, man, you walked in, you must be depressed. Like, I don't ever do that. And when someone says, I'm crazy, I'm like, we don't talk like that around here, because that's not a good word to use when we're talking mental health, because it makes you think negatively about a diagnosis. So we have to use language that supports the diagnosis and the patients and supports treatment and not takes away from it. It's no different than when you hear someone say that a person who's a drug addict, this person's clean. So what's the opposite of clean?
Dirty.
So if you're a drug addict, you're dirty, right?
Right.
It's language. It's knowing what to say. We say sober, because that's not a negative connotation of, well, if you're on drugs, you must be dirty.
Right.
Because if you're not on drugs, you must be clean. Like, you have to learn how to do this, and that's a dance that you have to dance. And learning how to do that dance takes skill, takes training, takes time, takes experience. And that mental health piece is huge, because people have to trust that you are not going to give them something that's going to make them worse.
Right.
It's going to stigmatize them. It's going to put them in a place with someone who doesn't care, doesn't empathize, and it's just going to be a round robin or a merry-go-round of foolishness. And I bring that up because in the DPC space, we usually try to do the opposite. And that just makes it a lot easier when you have more time and you have to figure out how to take care of patients both with insurance and without. And if I can figure out how to treat people without insurance and get them amazing mental health care, imagine if I do have the luxury of a person who does have insurance.
Right.
It starts to get a little easier, and that's something we do here all the time. And we're very proud of it. And one of the things we talked about outside of the stigma piece, which you already know, like I said, I'm very mindful of the words we use when we're talking to patients, so I don't actually make them feel like there's a stigma when we're talking about their treatment and their diagnosis. Another thing is coordination of care. Right. So one of the things we talked about on a previous episode, and I'm going to pivot for a moment and bring it back to the mental health side, is that we have a nonprofit arm or a nonprofit partner of the clinic now. So we have the Byja Charitable Alliance. And by being that nonprofit 501c3, we're oftentimes looking for ways of using that and leveraging that to give people care at a transparent and affordable way. Why am I saying that? So one of the things that I said right out the gate when we get this thing rolling is any donations we get, we're going to take those donations and find ways to give people care at an affordable and transparent way. And one of them was what? Mental health care.
Yep.
So we have literally found people in the community that are taking patients who don't have any insurance and getting them an affordable rate to get mental health care where Dr. Jasper can't handle it all by himself because he's not an expert at everything. He knows where he's good and where he needs to stop. So then I pick up the phone and call these mental health professionals and say, this patient has no insurance, but we need them to get care so they don't have the worst depression and worst anxiety ever and no one can treat them. How much will it cost? And they tell me what their number is. And we say, okay, so if the number's paid, you just take care of the patient. And you know what they say? Absolutely. They don't care about insurance. Neither do we. Why? Because that is an extra burden if we have to deal with all that navigation and coordination of care. So that nonprofit arm allows us to do that, which is something you would never have in a traditional setting, because in a traditional setting, it's, do they have insurance? Yes. If they do, this is where we're sending them. If they don't, then we're kind of screwed, because then at that point, you just kind of trying to figure it out. So how about you just create the system that allows people to get better care? To me, it sounds really simple, but we make it more complex. And that's why I brought up the idea of the coordination of care has to be something you're thinking of before they even come in the door. I'm thinking of, who am I going to send so-and-so to if they present with this issue before that happens, because when it happens, I'm already ready. It's not now I got to go figure it out. And that's why it's so surprising where you have the traditional setting of, well, why is the system so bad and all of that? Well, there's so many things we can point to, but one of them is the coordination of care piece. It doesn't exist until you have insurance in the mix, and that's when you have all these very siloed networks, and that really makes it hard when a person falls outside of that.
So what you're saying is patient A, patient B, and patient C can have similar diagnoses, right?
Yes.
And they can have a different plan of care depending on the situation?
Depending on that situation, their insurance, their background, their means, their method of transportation. If we had enough time, I could tell you the same patient with 3 different outcomes because of 3 different sets of settings. Whether it's a person with Medicaid, a person who doesn't have a car, and a person who potentially has all of the means, both private insurance and a car. Like, you may think, okay, well, that's kind of basic, but that's sometimes all it comes down to.
So would you say that's an advantage of your clinic versus another random clinic? It just in your skill set, in the terms of just, that plan of care.
Yeah, I know it's an advantage for us. It's almost to the point where I can't say it in the way that I think it sounds when other people say it, right? When I say how great we are, they're going to say, of course you're going to say you're great, because everybody does that. But when other people speak it for us, that you need to go see this clinic and you need to see this doctor because they're doing something different over there. And when they see it for themselves, it's really one of those things of, once you see it, you understand. Like when I talk to you, and I'll use you for example, if there's something that comes up and I say, you got 3 choices, that sounds a lot better than saying, this is what you're doing. And for that choice that you have, you can make this decision that works best for you. And even if the first one doesn't work, we still got 2 more that we can use. It's a lot better than, well, the only place we can send you is this place because that's the only one that takes your insurance. Rather than you have out of pocket, you have insurance base, and you have something where there's possibly a mixture. Which one would you prefer? And then if I can tell you, well, this is how much the out of pocket one costs, and it's a lot faster because now we don't have to worry about the insurance stuff. You may say, you know what, that's a better choice for me versus, look, I don't mind waiting. I'd rather go through my insurance because that's going to be a little more affordable. It really makes a difference on things like mental health care, where oftentimes a lot of it is not covered by your insurance.
Right.
You're trying to see a counselor or a therapist, and the counselor or therapist, you need to see them once a week, but your insurance pays once a month. Then what?
Right.
So bad outcomes happen a lot more often in our system. I do think we do it a lot better because we're knowing how to do a lot more with a lot less.
Well, since you use me as an example, I'll say this. I appreciate the collaborative approach. It puts some of the onus in my lap where I'm not just waiting for you to tell me what to do. Whereas I am helping my health and making that decision instead of just waiting for you to just say, hey, nah, bro, this is what you have to do. You do this, do that, do this, do this. And I'm actually thinking about it, doing what's best for me, and I'm empowered to do so.
Yeah.
So that's a major difference as well.
Yeah. And the one other part I think should go without saying, but I think we have to say it, is that there are going to be challenges during anybody's treatment.
Sure.
Every treatment's not going to go flawlessly, right? And if we have the approach of, when there's an issue that pops up, we have collaboration that's already in place. We also have multiple ways to solve this problem. We're going to have better outcomes. It's not going to be a one size fits all. It's not cookie cutter. It's not a recipe that you follow. There are certain things that you have to look at the person themselves and make sure it makes sense, make sure it's a good fit, and make sure that people are willing to follow your lead when you give them that diagnosis, when you give them that treatment plan, when you give them the things that are not necessarily the best in their labs or in their plan of care. You're trying to explain to them ways that you want them to stick around and listen, and people have to literally be willing to do that. So when we have people who do that, it works very well. When you have people who don't, it's not saying that it doesn't work well. To me, it's more so you have to be willing to pivot, because there are going to be some troubles, and the troubles are going to happen. But as a song I know says, trouble don't last always.
It does not.
So if it is something we can do creatively, collaboratively, and do it authentically, we'll have a lot better approach and outcome for those patients. And I will kind of wrap up the mental health conversation by saying this. When you go into that office, if there is a conversation of mental health care, much like anything else, it takes practice for both the physician side and the patient side. I've told patients plenty of times, if I'm giving you a medicine or therapy for as a recommendation for mental health, it may not go right the first time. But don't say it went badly in that first conversation, second conversation, I'm never doing that ever again, and I'm just going to do it myself. Because if that happened with you having an infection and the first antibiotic didn't work, are you just going to keep doing it yourself? If the first antibiotic gave you a reaction, are you going to keep doing it yourself? So mental health is no different. It takes time sometimes. It takes multiple efforts. The first medicine may have caused a negative side effect. The first medicine may have not done much. It didn't make you feel any better. The first therapist wasn't that good. The first therapist came in and gave you something that you didn't really want to hear. Doesn't mean all of them are the same. So I'm constantly having the conversation with people about mental health, not because I want you to have mental health issues. It's actually the opposite. I don't want you to have mental health issues. If everyone walked into the door and said, Dr. Jasper, I'm feeling great, nothing's wrong, and I'm happy as all get out, my job is so much easier. The amount of stuff I have to write down and document, if you tell me that, is nothing. It literally is 2 or 3 sentences. But when you come in and you have a lot of issues, we got a lot more work to do. So I'm willing to go down that road and that journey with you. But you have to be willing to say, you know what? We're working on it. We're going to do everything we can, and we're going to get to a point where it gets better. And if this person is really doing the work, myself included, we're going to figure it out.
Sure.
But if you're not doing the work, the doctor's not doing the work, people are passing the buck, and the diagnosis is getting looked over, and no one wants it, don't be surprised when the outcomes are pretty bad. So all of that being said, I think we're slowly but surely going to close out for today. I do have a few more things that we want to touch on, just some good news, right? We're talking about a heavy topic today, but in the conversation of getting people better, we talked about it a little bit earlier. So one of the things, as I mentioned, is we have that nonprofit arm. And I'm going to definitely plug our website. So if you're out there, you're a listener, you want to check us out, you want to possibly donate, it is a tax-deductible donation if you do donate to the Byja Charitable Alliance. And the Byja Charitable Alliance website is www.byjaca.org. So Byja, C-A, Charitable, C-A, Alliance.org. If you go to there, you can definitely make a donation that's tax-deductible. And the tax-deductible donation goes so far. It's helping us do things like work with these independent practitioners that are allowing us to get cash pay pricing for these patients who have insurance and who don't. It also allows us to work where we are hopefully going to be able to deliver more affordable medication prices to patients who oftentimes don't have insurance. And more importantly, it's going to make it to where people know how much things cost up front. We're doing that creatively and effectively, so we consider doing that. And mental health is one of the things that we do inside the Charitable Alliance, where we refer people to mental health counselors who they can then talk to and not have to worry about stigma and worry about whether their insurance is going to cover it and worry about all of the things that come along in those barriers that we talked about earlier. Outside of that, the other good news that I will share, I'm going to do that at the very end because I think it bears mention of one huge thing that I'm proud of, but I'm going to pause on that for a second. So before we go there, I'm going to ask George, is there anything that he wants to mention in terms of takeaways for today? Any closeouts from today's episode that you want the listeners to know, and any good news that, George, you may have?
Well, I don't know if I got any good news, That
was good news, man.
Yeah, man. I'm still here. Any day above ground is a good day, right?
There you go.
But now I think for me, in addition to the admonishment I gave earlier about knowing your medical professional, I would say pay attention to your mental health. just always monitor it. Just be aware of what's going on, because in my own experience, I feel like it was easy for me to get in the rhythm of what's going on every day, and if there's something that's not really 100% right, it's easy to kind of sweep that up as adulting, if you will.
Yeah,
right?
Absolutely.
So I would say pay attention to your mental health. Like, always check on it, man. Like, even if you have a primary care physician that you trust, that you're comfortable with, if not, I know a guy. You just come in and check on that. Say, hey, I just want to check on my mental health, and see what's going on. And you may be dealing with some things that might be treatable, or that you might be able to get some assistance on, that you just chalked up to life. Yeah. So I would say just pay attention to your mental health. Always check on that, just like you would check on your physical body, your physical health, and just be aware. And that way, life doesn't have to be as hard as it is sometimes.
Yeah. I'll jump in and say, don't be surprised if mental health causes physical symptoms. We didn't talk about that in deep detail today, but it happens all the time.
It does.
You can have problems where you're feeling extremely anxious and it causes really bad chest pain or really bad headaches or trouble with sleeping. And same thing happens with depression, where you may feel like you're having something that causes low energy and inability to focus, and you don't realize that it is a mental health issue. That part doesn't oftentimes get talked about, because, as George just so eloquently put it, we just call it adulting. I'm supposed to be this tired. I'm supposed to feel this uncomfortable because, I got to take care of the kids, or I got to worry about these bills, and I have to worry about my elderly parents, and all these things that we tend to say out loud or to ourselves, but don't realize that it's just giving ourselves a pass of getting ourselves looked at and treated. I say oftentimes in my exam room, are you really wanting to get better, or are you just looking to get by? And if you're looking to get by, then we are in the wrong place.
Facts.
My goal is to help people get better, not just get by. And that takes work, and it takes very hard conversations sometimes. But when we do it right and we treat you effectively, you feel better. And when you feel better, my job is better. My job is hopefully done, but you live longer and you have a healthier, happier life. So that physical piece is oftentimes a true indicator that we need to get checked out, and we need to get in care sooner than later, and not waiting until things are the worst of the worst. So I think we're hitting all the points. I will potentially close out with the good news, and then we'll talk, George, about where people can find us, if that's okay.
That's fine. So that works for me.
So the good news that I'm sharing today, we partially shared good news about the nonprofit arm. People don't realize that we were working on the nonprofit arm for about a year, almost two, before we finally launched it. And we've been doing quite well in that space since then, much to the thankful appreciation on my part from a lot of supporters, people making donations to us to be able to give care to people in need, and hopefully in healthcare disparities. So we are saying thank you for that. But the other good news that I have is that I'm finishing my book. And I'm plugging the book, because what else am I supposed to do other than tell people that, hey, this has also been a lot of work, right? It's been about a year of me saying I'm going to get this done and finally getting it done. So we're right now in the final editing process. Once the editing is done, we are going to have a published date, hopefully of August 19th. August 19th will be the date that you potentially can go online and actually make a full purchase, but we're looking to potentially do a pre-sale before August 19th. So if you're interested in kind of getting your copy on the first wave, you can go online and get that pre-sale edition, hopefully sooner than later. And what we're going to do for that, we're going to literally take the book and put it on our social media, put it on our website, send it out in our newsletter, and email blast it out to folks. But if you're interested in doing the pre-sale or looking at the book, it is going to be forthcoming. And I'm going to at least tell everyone the potential title of the book. It's called The Byja Blueprint, an introductory guide to direct primary care for patients, physicians, and businesses. So it's basically an intro into DPC for people who are potentially on the outside saying, I want to know more about it, and I want to find a all-encompassing place to do that. So that Byja Blueprint book will be coming out August 19th. And again, check us out on social media and also on our website to hopefully get more information on where you can make that purchase. And as we have that actual pre-sale information, we'll share that as well. So with that, talking about social media, George, where can the people find you?
Well, first of all, I think I need an autographed copy of this book. I feel like I should have an autographed book. I think everybody would agree with me. Anyway, but y'all can find me on X, formerly known as Twitter, as George.Becnel, and you can find me on Instagram at Becnel Media.
All right. So for myself, you can find me on Instagram at DrBJasper, Dr. B Jasper. And then from a clinic standpoint, you can find us at www.byja.org for the clinic. Again, for the nonprofit division, we are looking at www.byjaca.org. And then, of course, for other social media for the clinic, we can be found at LinkedIn, Facebook, and Instagram at Byja Clinic, all one word. So with that, we will close out for today. Thank you all for listening in at the beginning of season 2. We are happy to be back. We've got probably some good things in store for you all. And I say probably because it depends on if George is going to do George things, because we know everyone comes for patient zero. I'm just the sidekick at this point because I get stopped regularly for random one-liners.
I don't believe that. I think you're the star of this operation.
We're going to agree to disagree. No one comes and quotes me from the show. No one does. I'm just saying that. I don't have hot takes and one-liners apparently.
Well, because the thing about it is, man, I might say a little something silly every now and again. You're the one, you're speaking at such a high level. Sometimes people can't repeat that. You know what I mean?
I got to water it down a little bit.
Yeah, man. You speak so intelligently and so eloquently to where it's like, how do you just mock that?
Well,
but then somebody could say it ain't tricking if you ain't got it. It's just easier.
Well, I'm only laughing because that almost brought us to the lovely statement that we all tend to hear whenever we're black and educated, which is what? He speaks so well.
Yeah, he speaks so well. He speaks so well.
He's so well spoken.
It's the most aggravating thing ever.
It's a backhanded comment.
It's a backhanded compliment. That's like telling a young lady that's a pretty black girl.
Yeah.
Like that type of thing.
Yeah, I think people just don't realize the reason why it's a backhanded comment is if you don't say that to everybody, right? Your non-black friends, your elderly people, elderly family members, if you don't say that to everybody, then eventually you have to realize, why are you saying that? Is it because you don't see a lot of us who speak so well?
Right. It's like I always hear they say, man, that Dr. Jasper is sharp. I've never heard anybody bring up a non-black person and call them sharp.
I told you at certain points.
Not just say that.
Is the compliment based on the person, or is the compliment based on certain parts of the person? Right now, if you think I'm sharp just because I'm sharp, that's fine.
But that's cool.
That's fine. But if it has absolutely nothing to do with me more than who I represent, so to speak, then that's a whole nother conversation. But yeah, the speak so well one definitely is here we go. Which you've been in the meetings with me when it happened before, and I'm just like, here we go.
And I'm like, oh Lord, here we go. Educated black man. Mm-hmm. Everybody look out. Yeah. But look, now I'm gonna make you laugh though, because there was one time where we were in a restaurant and we didn't get the best service.
Oh yeah. I
remember. And man, you ripped the waiter a new one, but you ripped the waiter a new one in such a calm but eloquent way to where I pull out my phone and was like looking up some of these words. like you just really went up, you really gave him a tongue lashing, and the way you did it was just so smooth. I was like, he don't understand half of what you're saying.
That's right. And the statement, reading is fundamental. I didn't understand it then, but the more you read, the more words you learn, and all of a sudden you're like, I can say it this way and it sounds so much better, or I can say it this way and it sounds so much more polite when it really isn't.
Right.
It's just knowing how to say those things in 3 or 4 different ways, much like medicine, right? You got to learn how to treat a problem 3 or 4 different ways.
Correct.
And if you can do that, you start to become a lot better than the average fill in the blank. So I'm okay doing enough to say, you know what, I'm going to work at this. I'm going to work at this podcast, right?
Yeah.
It took 12 episodes of us getting better.
Yeah, true.
Well, I'm sorry, 11 episodes. We took a break and we're hopefully coming back stronger. Same thing happens with medicine. Same thing happens with us writing a book. Same thing happens with us building, not like, this is not play over here.
No,
I don't think people realize. I've had people comment in the last several weeks, do you sleep? Is one of the comments I get regularly.
Yeah.
The answer is yes. Small amount. I'm joking completely. Clearly, we had a whole episode on sleep. I sleep very well. Trust me. And any of my frat brothers and my roommate from college, what up, Chris? I'll tell you, they know how quickly I will fall asleep on anybody.
Dude, very fast.
Very fast, right? Because at the end of the day, my sleep matters.
Yeah.
So
I've been at the house in mid-conversation, mid-drink.
done.
Look across the sofa, Byron sleep.
And my best part is, I'll wake up like, y'all have the problem. Clearly, my body knows what it needs.
Right. Me and Dr. Mrs. Jasper. Which one you say first? Is it Mrs. Dr. Jasper or Dr. Mrs. Jasper?
I call her boss.
Yeah. Me and boss.
Yeah.
We just talking because Byron over there, mouth wide open on the on the other side of the sofa, just sleep.
That's how you know it's great sleep at that
point, bro.
Right?
Like your mouth open, bro. Like you in REM sleep, bro.
Yeah.
Like you in Inception with Leonardo DiCaprio. Your mouth open, bro.
I'm in level 6 of Inception. I can see that.
Right.
I'm down different levels. So yeah. But getting back to my original point, I've heard, do you sleep? I've heard you doing so many things that's really impressive, and all these, and it's not me doing it because I'm trying to impress people. I'm doing it because I know I have a vision and I'm going that way. And I hope anybody who's listening realizes you're a part of that. George is a part of that. You know, he's always coming on the journey with me as far as being the first patient. Also, when I say we're doing a podcast, he's like, let's do it. And the hope is you surround yourself with people who do the same. Mental health is no different. You want to surround yourself with people who are going to build you and not tear you down. When you have a vision and a dream, they say, what do you need, rather than you can't do that. So I'm trying to build that village. If you are interested in being a part of that, again, we take donations. That's a part of it. You want to be a patient. That's a part of it. You want to come and help us grow the podcast. That's a part. I mean, the amount of opportunity is there. Buying the book is a part of it, right? I'm not saying it because it sounds like, oh, we're just self-promoting. My point is, if I can get more people to understand who we are and what we're doing, we can grow and build something better. And that's what we're doing overall. And that's even when I don't speak so well. I mean, it's just something that we're going to do.
Yeah,
right?
absolutely.
So we're working over here. George is working roughly 90% of the time. The other 10%, he's thinking of donuts, which is completely not appropriate.
And
especially at the beginning of a health podcast.
So to be fair, I'm not eating the donuts.
Just thinking about.
I'm just thinking about the memory of donuts.
Very, very, very Homer Simpson-like, right?
Because I eat 2 donuts right now, bro. I'm gonna need your help.
It's a wrap.
I'm gonna need some assistance. It's not gonna be a good couple of days for me, bro.
Not at all. So we'll make sure we get you treated. That's all I'm saying.
Yeah, you're gonna need to do some treating.
With that, we again will close out the first episode of season 2, episode 12 overall. Thank you all for listening. Check us out on those various websites, social media. Look out for the book. If you want to donate, do that as well. And we will see you all shortly. Peace.
Hi, Dr. Jasper. I just wanted to say how much I appreciated your recent episode on high cholesterol. The way you broke down the facts and explained the risks and management strategies was incredibly clear and helpful. It's great to have such valuable information presented in an easy-to-understand manner. Keep up the fantastic work.